Welcome to SROA SoundBoard, a podcast for radiation oncology administrators. I'm Tammy McCausland. I'm joined today by Ann Hubbard, Director of Health Policy at ASTRO, and Dr. Constatine Mantz, a radiation oncologist and Chair of ASTRO's Health Policy. Welcome, Ann and Dr. Mantz.
Thank you, Tammy.
My first question is, why did ASTRO develop the radiation oncology case rate value-based payment program, also called ROCR?
Ann, I'd be honored if you answered.
Happy to. Thanks, Dr. Mantz. So as you may know, Tammy, radiation oncology had basically been part of an APM that was introduced by the Centers for Medicare and Medicaid back in 2019. And ASTRO spent a lot of time working with the agency trying to fine-tune that model. Foundationally, it was correct because it established a episode-based payment for RT services. And the challenge that we ran into with that was that it basically applied a series of cuts on top of that base payment, in addition to some administrative burden around, quality reporting requirements around reporting clinical data elements and that sort of thing. And so the agency finally came back in August of last year and said that they were going to indefinitely delay that model, but they weren't necessarily going to walk away completely from the idea of establishing episode-based payment for radiation oncology. And so that really kind of gave ASTRO the opportunity to take a step back, because there were aspects of episode-based payment that really work for radiation oncology. For example, if you basically move from payment that is per fraction to payment per patient, then you're really giving radiation oncology that opportunity to really take full advantage of greater use of hyperfractionation. And so really gave us an opportunity to establish ROCR, the Radiation Oncology Case Rate Program, as a way to basically make that shift from fee-for-service to payment per patient, while also at the same time kind of creating that room that's needed for greater use of hyperfractionation and protecting payment rates well into the future.
So can you provide a brief overview of the ROCR model and maybe highlight how it differs from the ROAPM?
Sure. So the ROCR model establishes a case rate that really is based on the M codes that CMS produced as part of the RO model in the Medicare Physician Fee Schedule 2022 final rule. And so those case rates were reasonable. What the challenge was that under the RO model, on top of those case rates, there were additional cuts. With ROCR, we're taking those case rates and trending that data forward to 2024. So recognizing that the value of services increases over time, right? And then we're also applying inflationary updates to ROCR. And that's something that was not used in the RO model. In fact, the RO model establishes very onerous discount factor, as well as a series of withholds for quality measures, reporting and other things. What ROCR does instead is it takes that case rate and adds to it an inflationary update to both the professional component and the technical component year over year. And then it applies a savings adjustment to generate some amount of savings, $212 million over the initial 5-year period to CMS. And so with ROCR being applied across the country, that equates to about $17,500 per practice per year. And so what ROCR effectively does is it applies that inflationary update, a little bit of an adjustment for savings for CMS, but it also applies a couple of other factors that I think are really important. It does recognize that there is a need for kind of a quality type assessment, and we're doing that through accreditation. So a practice can get a little bit of a bump in payment if they're accredited by ASTRO, ACR, or ACRO. It also applies a health equity achievement and radiation therapy payment for those patients, who may have trouble accessing their radiation therapy treatments. One of the things that we've done as far as working on health equity issues in radiation oncology is recognize that a lot of patients who either are from minority populations or rural socioeconomically disadvantaged populations have challenges with initiating and completing their treatment, because as you know, radiation oncology takes place over a period of time. And so with this HART payment, we would generate an additional $500 for those patients that require those transportation supports to make sure that they initiate and complete their treatments. Those are things that the RO model did not include. In fact, the RO model had the onerous merit-based incentive payment quality measures that were, similar to MIPS, and it also had the clinical data elements, reporting requirements that were not only onerous, but there really was no plan that the CMS had issued as part of how those data elements would then inform future model developments. So what ROCR tries to do is it takes kind of that concept and simplifies it and provides radiation oncologists with more of a viable payment structure in order to establish the rate stability that we're looking to achieve.
What kind of feedback have you been getting from cancer centers as you're, introducing the model and trying to move forward with this as something that CMS should adopt?
Sure. So just to kind of step back around the adoption really quick, the model would not be adopted by CMS. We're actually proposing to do this through a legislative initiative. Yeah. And so ultimately, yes, CMS would have to operationalize the model, but we're planning to pursue this through Congress. So that's kind of just one of the pieces I wanted to make sure that was pretty clear. But the feedback thus far has been fairly positive. I think many radiation oncology clinics recognize that they're really struggling under the current fee-for-service financial structure, and there needs to be a way to establish a rate stability across the specialty. Otherwise, it's going to be more difficult for practices to continue implementing, hyperfractionated regimens of care, and it will be difficult for practices also to invest in the capital equipment they need to operate.
So thanks for clarifying about the legislative path. Why is the legislative path better than the other route?
So, we worked with CMS for a long time on the RO model, and part of the challenge we found with making adjustments to the RO model was that the agency was to some extent restricted with regard to what they could do because of the Medicare and CHIP Reauthorization Act, which had some pretty specific requirements around how alternative payment models could be developed. For example, there's a requirement for nominal risk, and the agency and the actuaries that were involved with the RO model determined that the nominal risk requirements associated with macro weren't being met under some of the changes that we wanted to make to that. And so given the fact that the agency to some extent is tied to those requirements, we think that we're going to have more success going to Congress and seeking the ROCR payment program that way. And part of that is due to the fact that, as we were working on the RO model, we went to Congress a number of times and asked them for help with delays. So we have a number of congressional champions that we've worked with over the years, and we've secured their support. They recognize that radiation oncology really is kind of a unique form of medicine, and that the capital cost and the rate instability that have been experienced over the last several years are not sustainable in the long run. And so we think that the members of Congress are more likely going to be able to give us that opportunity to create some rate stability through the ROCR program.
Plus, I think you've mentioned hypofractionation, and a lot of, there's several different kinds of cancers where hypofractionation is becoming the norm. So it almost seems like the reimbursement needs to change in order to take into account that, you're not going to receive 35 payments for breast cancer if you're only doing 5. So it's good that you've addressed that. Dr. Mantz, as a practicing radiation oncologist who's also engaged at the health policy level, what are your thoughts or impressions of the ROCR model versus the ROAPM in terms of the practical implementation part of it?
Well, I think what really failed the RO model from the perspective of the physician who might be a participant in that model, and this is Medicare's program, this is not ROCR, just to make the point clear, that it really did not achieve a stability of payment for services as it had purported to do as a goal. That the payments would ratchet down according to changes that were observed under fee-for-service. That there may have been a delay in that ratcheting down, but inexorably, that's what would happen. And declining fractionation for some of our high volume diseases, such as breast and prostate cancer, would not be held harmless from a revenue perspective under the RO model, that they would be at risk as they would have been under fee-for-service, original fee-for-service. That, in addition to creating some upfront cash flow problems that, as Ann had referenced at the start, that steep discounts were applied right off the top of these episodic payments. And then withholds of 1% to 2% were further applied off the top, which created an opportunity later for the physician in the practice to recoup those withhold funds, but took them off the table at the start of the case. And when you begin to look at this accrual of discounting and withheld payments, that it really pressed down significantly on a center's ability to operate well in order to meet its capital expenditure and operating expense needs, particularly if that center, like many rural centers do, depend very heavily on Medicare and other federally funded payers for their business. And so we thought that this was not going to be a functional model, and in many respects was disadvantageous compared to original Medicare fee-for-service. And so we advocated very strongly against it, and then we were pleased when ultimately, through the Congress and its support, that the agency decided to place the model on an indefinite hold.
Can you share some data points that were shared in a WebEx meeting regarding the impact?
The couple of data points that I could share, I'm just kind of looking around the current situation that, radiation oncology finds itself in the current fee schedule, the 25% cuts over the last decade, and how those cuts have had a significant impact on the top 3 disease sites. When we look at, standard of courses of treatment for breast cancer, the value of those services is down 18%. The value of, prostate cancer is down 30%, and lung is down 34%. A lot of that has to do with the fact that we sustained these cuts under the fee schedule over the last decade. In fact, it's down most recently once the proposed rule came out between 2013 and what they're proposing for 2024. Radiation oncology is down 25%.
So why do they keep cutting it when they know it's so expensive?
So there are a lot of kind of other things that are going on within the fee schedule. And, a lot of it has to do with the fact that CMS believes that it needs to shift more payment to primary care services, to preventative care services. And because the fee schedule is a budget neutral funding system, there, you take a little bit from one place and you have to shift it to another. There's no, it's not an infinite pot of money. And so what has happened over the last decade is that through a series of efforts to kind of shift things around, radiation oncology and other capital intensive services have really been hit. And so, some of the things they've done, they've changed the E&M codes and how those codes are valued. So that's been, a shift in payment towards more medical services that are preventative and for, primary care focused. There's been an update to equipment expenses, and that wound up shifting money around. In fact, radiation oncology, in a couple of instances, we saw equipment rates decline by as much about 10%. I think that was actually for stereotactic surgery. And then there was also the shift in the clinical labor inputs that just happened most recently in 2019. And, that was the clinical labor price inputs were something that we supported because that increased the value of the services delivered by medical physicists, dosimetrists, members of the radiation oncology team. But in order to do that, that shifted payment away from those capital intensive services, which, really is the bulk of the value of the radiation oncology code set. Mm-hmm. And so that's been a real challenge for us. Mm-hmm. I don't know, Dr. Mantz, if you had anything to add to that.
No, that's it. I mean, radiation therapy, in addition to a few other specialties, but maybe especially radiation therapy, has been disadvantaged by Medicare's payment policy over the last number of years. And as Ann stated, there's a fairly explicit initiative on Medicare's part to shift this fixed pot of healthcare dollars toward E&M services, which we support, and toward labor-intensive services, which we also support. But it puts a field like ours, where we have to make commitments to very expensive equipment and to hire expensive staff to help operate that equipment and do so at a high level of quality, to try to find ways to continue to operate and provide a high standard of care as we would want and our patients expect, and as I think the Medicare program would demand. It's difficult when payments go down, when you can't trade out a piece of equipment for something that is lesser expensive. Linear accelerators are fixed expenses and they're very high CapEx, and your commitment to making payments to meet the demands of having to have such equipment in your facility do not get ameliorated because Medicare decides to cut you by 3 or 4% year over year. And so I think for that reason, and there may be a few other points that we could make, but maybe that's the most important and largest contributor to the overall problem that radiation therapy faces, is that we have, I think, special needs that are just not being met well by either fee-for-service at present, as we stated, that it doesn't support hypofractionation and other higher quality, higher technology services that we may render to our patients, and that Medicare's payment policy, which intends to be applied across the universe of healthcare services, really doesn't cohere well with our needs. And so we're looking for an alternative way.
So let's assume a scenario in which ROCR is implemented. So will it become mandatory for all cancer centers across the United States to participate in it?
As we have it drafted at present, that it would be mandatory, that all providers or all facilities that participate in the Medicare program would be a part of ROCR. And to drill down into what falls within the scope of ROCR and what doesn't, is that ROCR has selected the 15 most common condition types, cancer types, that are treated with radiation therapy, which in the aggregate account for about 85% of the total case mix. That, of course, includes high volume diseases such as prostate cancer, breast cancer, lung cancer, bone mets, brain mets, and so on. For the remaining 15% of cases, that they would continue to be paid under fee-for-service.
And to administrators who went through all the pains of the metrics of the ROAPM, what would you tell them that would be different under ROCR?
I think we would tell them that, one, you would see an uplift in your projected revenues under ROCR relative to the ROAPM, and that uplift would be sustained through an inflationary adjustment that was absent from ROCR, that we would tie the reimbursement of these base rates to prevailing inflationary indices that Medicare already uses to price goods and services in other parts of the overall program. And from an ease of administration perspective, that the burdensome reporting requirements of clinical data elements and other very specific and punctate items of information that are difficult to extract out of our EMRs and other information management systems, that burden would be completely lifted, as well as participation in the MIPS program with its own unique set of burdens, in exchange for the practice pursuing and obtaining practice accreditation status, with an exception applied for small practices, by the way, that they would not be obligated to go through that expense and trouble. But for all other practices, that practice accreditation, which we feel is a much more pertinent measure of practice quality, a much more comprehensive review of policies and procedures and coordination among clinical care teams, technical proficiency, all those facets that define a high-quality radiation therapy program, that status would do a far more effective job of determining quality than just reporting on some random number of quality measures.
Those are very good points. You both kind of alluded to this already, but I'm just going to ask the questions kind of as a recap or overview. How will ROCR take into account different size cancer centers, like the rural freestanding academic medical centers, and not be the one size fits all?
Right. Well, there is some adjustment according to geography under ROCR that, as happens presently under Medicare fee-for-service, where there is a geographic adjustment made to an RVU or to a HOPS payment to account for the different costs of delivering healthcare in different markets, that those same adjustment factors would be applied to the ROCR base rates in order to address those differences in the costs and the delivery of care. Otherwise, we feel that this would be of particular advantage for the smaller and particularly rural smaller facilities that see a great deal of Medicare business, much more so than your urban hospital and cancer center and freestanding center. That those are the facilities that are at greatest risk to go under if Medicare fees continue to press down. And this would at least allow some stability for those payments that will determine a very large share of their overall revenue. We think that this is a real advantage for that type of facility. And so we're proud to promote that fact.
Yeah, and I would just add that those are also the facilities that will likely benefit the most from the health equity adjustment and radiation therapy or HART add-on payment for transportation services.
Mm-hmm. Yeah. And for administrators who either want to learn more about ROCR or get on board, so to speak, in terms of helping to move it forward on the legislative path, what advice would you give to them?
Well, Ann and I are pretty easy to get a hold of.
Yep.
And so I think, if points of contact are needed to discuss ROCR from a design and administrative perspective, or from a physician practitioner perspective, I think you could do worse than contacting either one of us. But I think as we move forward, ASTRO will continue to deliver on providing educational materials, especially at the upcoming meeting, which we encourage people to attend, where we will have sessions devoted to ROCR, and we'll open the floor to questions and invite them in that venue. We also invite ASTRO members to submit questions through the ASTRO website, which we'll happily address. And as we move forward with this, and if it looks as though it continues to gain momentum, that we will reach back to our membership and other interested stakeholders to advocate on its behalf with its members of Congress.
So what is next in terms of trying to get ROCR, passed into law, especially given there's an election? I know it's not till the end of next year, but I know the election takes priority many months earlier. So I was just wondering, what are you hoping for or trying to achieve before the next election?
Well, there are windows of opportunity that you try to identify, and thankfully we have lobbyists and consultants that work on the Hill and have long and deep experience with trying to include language or enact language into legislation for a purpose like this. And you're right, maybe at this moment it's not the best time to push on this, but those windows open and shut continuously, and we're just going to look for the next reasonable opportunity.
Yeah, in the meantime, it's really important that we continue to lay the groundwork and continue our conversations with members of Congress, as well as others in the radiation oncology stakeholder community.
Great. Do you have any final thoughts that you'd like to share?
The only thing I would add is that I'll be at the SROA meeting on October the 4th. So I'm looking forward to seeing everybody there, and certainly happy to answer questions about ROCR there as well.
Okay. Thank you for your time today. I really appreciate it. It's been an insightful conversation.
Thank you, Tammy.
Thanks, Tammy.